This is the second video regarding bone tumor, and it will discuss the osteogenic tumors. These are the references for this video. By the end of this video, we will try to find the solution to these clinical problems. First is a 19-year-old boy present to the emergency department complaining of right lower thigh pain following a fall. And second clinical scenario is a 13-year-old boy present to your office complaining of pain and swelling in his left knee. He denies any trauma to the knee and has no fever to suggest an infectious process. The osteogenic tumor or bone-forming tumor accounts for about 32% of the primary bone tumor. The benign tumors are osteoma, osteoid osteoma, and osteoblastoma, while the malignant counterpart is osteosarcoma. The osteoid osteoma and osteosarcoma tend to affect the metaphysis of the lung bone, while the osteoblastoma affect the vertebral column. All these osteogenic tumors tend to affect the patient in their adolescence. The osteoma is a bone-forming tumor, and it is a benign tumor composed of compact cortical bone. By some scientists, it has been regarded as a hematoma rather than a true neoplasm. There are 4 clinicopathological subtypes. One is the calvalular and mandibular osteoma, another is the osteoma of the sinonasal and orbital bones. Third is the orbital island occurring within the medullary bone and surface osteomas of the long bone. They are associated with the familial adenomatous polyposis in Gardner syndrome, and when associated with this syndrome, they are multiple. On radiology, they look like dense ivory-like bony mass, and on histology, they are well differentiated, mature, lamellar bony trabeculae separated by fibrovascular tissue. This is a CT image of osteoma. There is a rounded bony cortical irregularity which is marked by this golden arrow, and it is extending into the left maxillary sinus. These are an incidental finding in the Gardner syndrome. Solitary osteomas occur in middle-aged adult as sessile, periosteal or endosteal masses. Osteoid osteoma and osteoblastoma are bone-forming tumors. They both have got similar histological features, but different sizes, site of origin, and symptoms. The osteoid osteoma is composed of immature osseous tissue, which is termed as the nidus, and this is surrounded by the halo of a dense reactive bone. These are rare and benign tumor, and the size of the nidus is about 1.5 to 2 centimeter or maybe less. 75% of the patients are under the age of 25 years, and male, 2/3 of these patients are male. 50% of the cases are recorded in femur and tibia. The other sites are humerus, hands and feet, vertebrae and fibula. The cortex of the metaphysis is the most common site in long bones. It presents with an intense localized pain, particularly during night when there is more production of prostaglandin E2 or nerve fiber in the reactive zone. Pain is also exacerbated by drinking alcohol and relieved dramatically by aspirin and non-steroidal anti-inflammatory drugs. This radiograph is showing an osteoid osteoma which is present in the femoral neck. So these osteoid osteomas are associated with the structure of the abnormalities of the chromosome number 22, the long arm of the chromosome 22, and loss of part of the long arm of the chromosome 7. The gross appearance of this osteoidostoma is a round to oval, well circumscribed mass of the hemorrhagic gray tan tissue, and the nidus, which is the actual tumor, is 1.5 centimeter or less. It is red, granular in appearance, and it is softer than the sclerotic tissue and has got distinct features. It is surrounded by a sclerotic bone for several centimeters, as it is evident by these pictures. The picture on the left is showing the gross specimen of an osteoidostoma, and there is a central granular red and soft nidus which is embedded in dense bone, while the picture on the right is a specimen radiograph of intracortical osteoidostoma, which is containing a round radiolucency with central mineralization representing the lesion that is surrounded by abundant reactive bone, and this reactive bone is resulting in cortical thickening. The radiograph on the left is showing a discrete round radiolucency surrounded by a thin rim of the sclerosis in the proximal phalanx, and it is marked by this golden arrow, while on the right side this CT scan, this image is showing the osteoidostoma which is present in the proximal femur. The osteoblastoma is also a bone forming tumor, and it is also termed as giant osteoidostoma. These are rarer than the osteoidostoma and about 25% as common as osteoidostoma. The mean age for the osteoblastoma is 20 years, and the age range is 10 to 35 years, though it can affect the patient at any age. 2/3 of the cases are male. This osteoblastoma is related to osteoidostoma, but it has got a larger nidus which is more than 2 centimeter, and the reactive bone formation is variable. There is lack of intense pain. The pain in this osteoblastoma is dull and achy, and it is not related to the aspirin. Rarely, this osteoblastoma has got systemic manifestation of weight loss, fever, and generalized periostitis, and in these conditions, this is termed as toxic osteoblastoma. The site for the osteoblastoma is spine usually, while sacrum is also affected in 1/3 of the cases. The major bone of the lower extremity, medulla or metaphysis are also affected. The molecular pathogenesis of the osteoblastoma, there is aneuploid to hyperdiploid karyotype, MDM2 gene amplification, and P53 gene deletion. The osteoblastoma has got almost similar morphology, except the size is different. The nidus is more than 2 centimeter in osteoblastoma, and grossly there is a red granular well circumscribed nidus, and there is variable surrounding sclerosis. This picture on the right is showing a spinal osteoblastoma with central nidus involving the pedicle. The histologic appearance of the osteoidostoma and osteoblastoma are almost same. The histology is described as randomly interconnected trabeculae of woven bone. These are rimmed by a single layer of prominent osteoblast and surrounded by loose connective tissue, and there are many dilated and congested capillaries which are responsible for the red color of the nidus grossly, and the relatively small size, well-defined margins, and benign cytological features of the neoplastic osteoblast, they help to distinguish These osteoid osteoma and osteoblastoma from osteosarcoma. The reactive bone encircles the actual neoplasm or the nidus, which form a small radiolucent core that may be centrally mineralized. This is the CT image of the osteoblastoma, which is marked by this red arrow. There is an expansile lytic lesion with the central nidus in the posterior arch of the thoracic vertebral body. This lesion is similar to the osteoid osteoma but is larger than the 2 centimeter. Mostly it involves the dorsal elements of the vertebrae in adolescence and young adult. A fourth of these lesions may have destructive growth resembling malignant bone tumors. The osteoid osteoma is treated by the radiofrequency ablation, while the osteoblastoma is treated by curettage or en bloc excision. Recurrence is uncommon for both the lesions. The osteosarcoma is another bone-forming tumor, and it is the most common primary bone tumor after the myeloma. It accounts for about 1/5 of the bone cancer, and it arises from the primitive osteoblast forming mesenchyme. The osteosarcoma can be defined as the malignant bone tumor that produces osteoid directly from the tumor cell and unconnected with the cartilage, regardless of the amount of neoplastic cartilage or fibrous tissue that is present elsewhere. The age of onset of the osteosarcoma, this tumor is bimodal. There are 2 varieties, primary and secondary. Primary is the condition or osteosarcoma which is present in the absence of any other disease, and it occurs in younger age group, the people below the age of 20 years, and it accounts for about 70% of the cases, while secondary osteosarcoma is present in old age after the 4th decade of the life, and it is usually associated with some other underlying condition such as Paget's disease. It can occur after radiation and after the administration of thorotrast. This thorotrast is radioactive compound thorium dioxide containing suspension. This was earlier used as radio contrast agent. Then chemotherapy in children is also associated with osteosarcoma, and the associated other bone pathologies such as fibrous dysplasia, osteochondromatosis, chondromatosis, and rarely the hip implant also contribute to the development of this secondary type of the osteosarcoma. The trauma is not associated with this osteosarcoma, although trauma may lead to the discovery of the tumor. It is slightly more common in men, and the male is to female ratio is 1.6:1. So this osteosarcoma is more common in tall people, and it is also associated with radium wash dial painter. These radial wash dial painter used to wet their brushes by licking them, and there was subsequent deposition of this radium within the bone. However, the external therapeutic radiation is more common etiological factor these days. Just to emphasize again, the pre-existing benign lesions of the bone are also associated with osteosarcoma, and these are fibrous dysplasia, osteomyelitis, osteogenesis imperfecta, osteochondromatosis, chondromatosis, and osteonecrosis or bone infarct. The osteosarcoma is more common in the metaphysis of the long bone, and the most common bone involved are distal femur, proximal tibia, or proximal humerus. These are the sites of peak mitotic activity for the bone cells. Occasionally diaphyses and rarely epiphyses are also involved, and it is more common tumor of a long bone, and it is less common in flat bone or short bones, and this tumor usually arises within the medullary cavity and extends to the cortex. Clinically it presents with pain, progressively enlarging mass, or sometimes with pathological fracture. The enlarging mass forms a destructive mixed lytic and blastic mass with infiltrative margin, and the tumor infiltrates through the cortex and elevates the periosteum. This tumor also induces periosteal bone formation, thus form a triangular shadow between the cortex and elevate the periosteum. This elevated periosteum on X-ray, termed as Codman's triangle. It is an indication of the aggressiveness of the tumor, and this is a non-specific finding. It is just mentioning or depicting that there is a reactive bone formation, and this elevation you can see by the is marked by the arrows, and there is osteogenesis also in the tumor, which give rise to the pattern like rays or beams radiating out from a center in a manner of the sunbeams. So this is termed as sunburst pattern. This is an X-ray of the lower end of the femur with a radiodense mass exhibiting sunburst pattern in the lower metaphysis and diaphysis. The bone architecture is obscured due to radiating radiodense bone. This is a MRI of the distal femur, and it's showing extensive cortical bone disruption and extension of the tumor into the surrounding bone tissue, which is marked by this yellow arrow. Areas of cystic degeneration and hemorrhage are marked by the variable intensity of the brightness. The peak incidence of the tumor is during the period of growth, that is adolescence, and the tumor site is near the growth plate of rapidly growing bone, such as the femur, tibia, and humerus. The increased proliferative activity predispose to mutation that lead to the formation of the neoplasm. There is about 70% of the osteosarcoma, they are associated with acquired genetic abnormalities. One of the genetic abnormalities is RB mutation, and it is present in 70% of the sporadic cases. However, the germline RB mutation, if it is present there, it increases the possibility of osteosarcoma 1000 fold. Then this TP53 gene is also present in germline mutation and is a component of the Li-Fraumeni syndrome, and it is also common in sporadic osteosarcoma. CDKN2A, which is also termed as INC4A, it encodes two tumor suppressors, P16 and P14, and if it is inactivated, it is also associated with osteosarcoma. MDM2 and CDK4, they inhibit P53 and RB function, and they are overexpressed in many low-grade osteosarcoma through chromosomal amplification in long arm of the chromosome 12. This picture is showing a bulky, gritty, grey-white tumor that is showing the areas of hemorrhage, and it is infiltrating into the marrow cavity also, and the cortex is also destroyed. So these are the destructive lesions, and there is destruction of the cortices, and these tumors expand. They tend to expand and infiltrate, and they form the tumor masses within the soft tissue. Also, these lesions spread along the medullary cavity and replace marrow. This tumor can also penetrate the epiphyseal plate, though infrequently, and then enter the joint. They tend to grow along the tendons and ligaments. This is the osteosarcoma of the lower end of the femur. About two-thirds of the cases of osteosarcoma arise around knee joint. In this picture, there is dense destructive lesion that extend through the cortex into the soft tissue and the epiphysis. This is another picture of the osteosarcoma of the lower end of the femur, showing a bulky expansile destructive lesion affecting metaphysis while epiphyseal cartilage is spared. The periosteum is also lifted up due to growth, and cortices are destroyed. In the tumor mass, there is presence of hemorrhage and necrosis. The histology of the osteosarcoma is characterized by the presence of polygonal or spindle cells with osteoblastic differentiation and producing woven bone. The malignant cells show features of anaplasia such as pleomorphism, both cellular and nuclear hyperchromasia. There is abundant and atypical mitosis also with giant cell formation, as is seen in this picture. The tumor cell tend to invade vessel, and necrosis is extensive in these osteosarcoma. The diagnosis is made by presence of malignant cells. These are producing osteoid or mineralized bone. This is fine and lace-like, as is seen in this picture, but can also produce sheets or primitive trabeculae. When these neoplastic cells produce cartilage, the tumor is termed as chondroblastic sarcoma. On immunohistochemistry, the tumor cells are positive for alkaline phosphatase, osteocalcin, and osteonectin. This illustration is summarizing the hallmarks of the histological picture of osteosarcoma. These are the presence of osteoid or osteoid formation by the malignant cell, the highly pleomorphic spindle or polygonal cell, presence of mitotic figure, atypical mitotic figures, and tumor giant cells. There are some microscopic variant of the osteosarcoma. These variants may be present focally or in combination, and some of these variants have got distinctive prognostic value. One of these is telangiectatic osteosarcoma, and this telangiectatic osteosarcoma is more aggressive in nature, present with pathological fracture and morphologically composed of blood-filled cystic spaces like aneurysmal bone cyst. The main identification is by the detection of malignant cell in the septi that separate the cyst. The small cell variant, this small cell variant shows uniform small cell aggregate, and this simulate Ewing sarcoma or lymphoma. But this is identified by their ability to form bone. The fibrohistiocytic osteosarcoma and the anaplastic osteosarcoma are recognized by their tendency to form the osteoid by malignant cell. The well-differentiated osteosarcoma, which is located intramedullary, is so benign looking that it can lead to the misdiagnosis of a benign lesion such as the fibrous dysplasia. It affects adults. Femur and tibia are the common site, and the rare site is the small phalangeal bones. Its recurrence is common, but it doesn't metastasize. This picture is of tibia, which is showing the interosseous well-differentiated osteosarcoma. The patient usually present with pain and tenderness with a progressively enlarging mass of the affected area, and the serum alkaline phosphatase is raised usually, while the serum calcium and phosphorus level are within normal limits. It spreads through the hematogenous route and often metastasizes to lung. 98% of the autopsies in which the death was associated with osteosarcoma, they showed the lung metastasis. Other site of the metastasis are to the other bone and pleura, which is present in about 1/3 of the cases, and to the heart, brain, and other sites. Treatment for the osteosarcoma, it is presumed that all patient at the time of diagnosis, they have got occult metastasis. Neoadjuvant therapy is given. This is the therapy which is given before the main treatment, and it helps to reduce the size of the tumor cell and debulk the cancer that have spread. And in addition to the neoadjuvant therapy, there is limb sparing surgery, and post-operative chemotherapy is also given to treat the osteosarcoma. The 5-year survival, if there is no metastasis, it is very good, and it's about 70%. If there is metastasis present, the tumor is secondary to some associated disorder, and if it is a recurrent tumor, the prognosis drastically goes down to less than 20%. The other variants of the osteosarcoma are defined on the basis of topographic, clinical, or radiographic feature, or combination of these features. The surface osteosarcoma is one of them. Surface osteosarcoma accounts for about 5% of the cases of the osteosarcoma, and there are two types of surface osteosarcoma. One is the juxtacortical or parosteal osteosarcoma, and another is periosteal osteosarcoma. The juxtacortical or parosteal osteosarcoma is a rare variant, and it occurs on the surface of the bone, especially the lower posterior metaphysis of the femur, and this location is involved in 70% of the cases. This parosteal osteosarcoma involve women more, and the age group affected is more than 25 years. The usual site is it spares the deep cortex and medulla of the bone, grows external to the shaft, and Codman triangle is absent. These are the low-grade lesions, and grossly these are lobulated, circumscribed, calcified masses in the subperiosteal location. The treatment is surgery, and they do not require any adjunctive chemotherapy. It is associated with a very good prognosis, which is more than 80%. The periosteal osteosarcoma arises from the inner germinative layer of the periosteum, and the cytologic grade of this tumor is higher than the parosteal osteosarcoma and lower than the conventional osteosarcoma, and they are considered as intermediate grade osteosarcoma or grade 2 osteosarcoma. These Periosteal osteosarcoma predominantly contain chondroid matrix. This is a parosteal osteosarcoma in a 40-year-old female in the tibia, and there is a large extracortical component of the tumor. This is the parosteal or juxtacortical osteosarcoma of the upper femur. The cortex is minimally involved, and there is lobular pattern of this tumor is recognizable. This is a periosteal osteosarcoma, which is another type of surface osteosarcoma. This cut surface shows white shining appearance due to high cartilage content, and the most common location of these tumors is located in the upper tibia and femur, and these are presented as a small lucent lesion on bone surface accompanied by bone spicules arranged perpendicular to the shaft. The main differential diagnosis is from juxtacortical chondrosarcoma, and some minor differences in location, microscopic grade, and behavior have been described between the periosteal osteosarcoma and periosteal chondrosarcoma. This table is describing the contrasting feature of central and surface osteosarcoma. The central or medullary osteosarcoma is more common between the age of 10 to 20 years, while the surface variety is common in older patients. The central medullary osteosarcoma is more common in male, while the surface parosteal osteosarcoma is more common in female. And when we consider both the parosteal and periosteal osteosarcomas, then there is no sex predilection. The central or medullary osteosarcoma are more common in metaphyses, while the surface osteosarcoma are common in metaphyses and diaphyses. The location for the central osteosarcoma is lower end of the femur and upper end of the tibia and upper end of the humerus and around the hip joint, while the common site for the surface tumor is femur lower end and humerus upper end. The central variety, central osteosarcoma, has got the primary and secondary causes, while the surface osteosarcoma the parosteal arises outer to the cortex, and periosteal arises between the cortex and the periosteum. The central variety of the osteosarcoma is highly malignant, while the parosteal and periosteal variety are slow growing. On gross examination, the central one is bulky, necrotic, and forms Codman's triangle, but the surface osteosarcoma is smaller and well formed, and Codman triangle is not usually formed. On microscopic examination, the sarcoma cells are polymorphic and pleomorphic, and the osteoid formation is there. In parosteal, fibrous stomal cell with subtle atypia are there, and periosteal has got a bit higher grade than that of this parosteal variety, and it is grade 2. Both form of parosteal and this periosteal variety, they form bony trabeculae. There are certain histological variants of this central variety that are telangiectatic, small cell fibrohistiocytic, well differentiated, and anaplastic variety, while the surface osteosarcoma are parosteal and periosteal. The parosteal is also termed as juxtacortical. The central variety is spread through the blood and the prognosis is poor, while the surface variety in this osteosarcoma, the recurrence is common, and they can metastasize, but metastasize rarely, Prognosis is very good for the especially for the parosteal osteosarcoma, and a bit bad for the periosteal, but this as these periosteal osteosarcomas are grade 2 tumors. Prognosis of the osteosarcoma, age, sex, and status of the pregnancy are not associated with the or do not affect the prognosis of this osteosarcoma. But if the osteosarcoma is associated with Paget's disease, it is highly malignant and mostly fatal. If there is history of the prior radiation, the survival is about 28%. It has got a better prognosis if it is affecting the jaw and distal extremities, and it is associated with a poor prognosis if the other craniofacial bones and vertebrae are involved. If the osteosarcoma is multifocal, it is uniformly fatal. The histological types are also associated with the or linked to the prognosis of this disease. There is a better prognosis for the fibroblastic type and well differentiated intramedullary osteosarcoma. The chondroblastic type is less responsive to the chemotherapy, and telangiectatic osteosarcoma has a worse prognosis. The osteosarcomas which are associated with increased serum alkaline phosphatase are associated with increased metastatic rate, and post-chemotherapy tumor necrosis amount is directly related to the survival. Now the aneuploidy, most of the osteosarcoma are hyperploid or aneuploid, whereas the parosteal and periosteal osteosarcomas are usually diploid. The presence of heat shock protein 72 correlate with the good response to neoadjuvant chemotherapy in osteosarcoma, while loss of heterozygosity of RB gene and HER2 neo expression are associated with poor prognosis. The presence or expression of the P glycoprotein in tumor cell at the time of diagnosis is associated with increased risk of systemic relapse, while parosteal and periosteal osteosarcoma are associated with an improved prognosis. So now we can answer the clinical scenario we saw earlier, in which a 19-year-old boy presented to the emergency department complaining of the right lower thigh pain following a fall, and X-ray showed a fracture in the stalk of the bone growth protruding from the end of his femur. You expect that the histological examination will reveal endochondral ossification over the medullary cavity without any atypia. So this scenario can be osteochondroma. The other problem we had, a 13-year-old boy presented to your office complaining of pain and swelling in his left knee. He denies any trauma to the knee and has no fever to suggest any infectious process. Laboratory tests reveal an increased serum alkaline phosphate, and X-ray of the knee shows a mass with a sunburst growth pattern and periosteal elevation by the mass, commonly called Codman triangle, and you suspect he will need chemotherapy and possible surgical resection, and you immediately refer this patient to an oncologist. This is the classical picture of osteosarcoma. A 16-year-old boy presents with a 2-week history of pain in his right leg. He says that he has been taking aspirin to relieve the pain, and X-ray of the leg show a 1 centimeter sharply demarcated a radiolucent lesion in the diaphysis of the tibia surrounded by dense sclerotic bone. The lesion is surgically removed and the gross specimen is shown in the image. Microscopically, the tumor shows irregular trabeculae of the woven bone surrounded by the osteoblast, osteoclast, and a fibrovascular marrow. What is the appropriate diagnosis? A 67-year-old man developed bow legs and leg pain over a period of 5 years. He has also complaints of progressive hearing loss over the last 2 years. A bone biopsy shows a mosaic pattern with prominent cement line and increased osteoblastic and osteoclastic activity. Serum electrolyte levels are normal. The patient is at increased risk of developing which of the following disease? A 12-year-old female had a 10.5 cm intramedullary mass in the distal femur, which was resected. High power view demonstrate bland spindle cell, and radiology is showing the sunburst pattern. Which of the following is best answer?